I agree. That's definitely not normal in
Right.
terms of one, the severity of our pains. Once you get to the point where you're having pains that is disruptive to your life and
Right.
affecting your ability to function, whether professionally or otherwise,
Mm-hmm.
then we're looking at something that's abnormal.
Welcome to the first episode of the Women's Health Podcast with Kim and Dr. C. I'm Kim, Kimberly Hoffman, registered physical therapist specializing in pelvic health physiotherapy. And we have Dr. C. Dr. C, tell the world who you are.
This is Dr. C. Leroy Campbell. I am obstetrician gynecologist and excited for us to serve you. So let's get into it.
Yes, let's get into it. So we want to start off with trending topics. We want to stay hip and trendy with the latest in women's health. What are the women out there doing? Is it good? Is it bad? Is it something we recommend? Is it something that we don't recommend? So this week, Doc, I'm always on Instagram looking through, checking the feeds, and I saw vabbing. And there was a disclaimer in the video, do not Google this. But of course, curiosity got the best of me. And I Googled it. And so vabbing is using the vaginal secretion as perfume. And they say that it has the effect of attracting the opposite sex. And women are doing this at the gym and going out in public. What do you think about this trend, Doc?
All right. So first of all, you have to ask me what's my personal opinion and then professional opinion. Is it? All right. I'll tell you the truth, Kim. This is the first time I'm hearing about vabbing. Sounds very interesting. So is it that they're trying to, they're assuming that there are pheromones that are coming out of the vaginal secretions? Is that what they're thinking?
That is what they think is happening, and it will attract the opposite sex.
Oh, whoa. Well, listen, I guess there's a concept of to each his own. I'm not sure how effective that's going to be. I can't recall any studies being done on how applying vaginal secretions as perfume is going to help with that. But, I can say a couple of things. First of all, let's hope they're washing their hands first before inserting the fingers, especially in the gym, because you don't want to be introducing any strange bugs into the vagina. And then, so that's one thing, the concern about vaginal infections. But also, let's hope that there are no infections that's present within the vagina. I'm assuming if everything is healthy, then it shouldn't be a big problem. But if there's something going on from an infection standpoint, then transferring that out and putting it on the ear and the skin and so.
And in the gym where other persons will probably make contact with equipment that other persons will be using.
Yes. Yeah. It's kind of sensitive. I think that one's a little bit concerning for me. I'm not sure if I'm quite there yet.
It's a no for me, Doc. It's a no.
That's a no for you. Yeah, I think that's a no for me too.
So, this week, Doc, I want to talk to you about a friend of mine. She's not the only one I've ever heard like the same situation with, but want to share it with you, and I want to hear, all that good stuff. I like to pick your brain. So, I have a friend, she's about my age, 28, 29. And she started having her period at about age 12, she's had horrible cramps. So really severe cramping. She would have to stop, she'd have to miss school every time her period comes. So she'd miss school 1 or 2 days every single month due to the pain. She said that her mother would take her to the doctor and they would say, well, it's cramps. It's gonna be bad. It's supposed to be bad. It's supposed to be painful, but eventually it will get better. But it never did. It continued straight into later teenage years, into adulthood. As an adult, when she started having sex, she would say, first sex is normally painful, but for her, it was excruciating. She doesn't even like sex because it's always so painful. And she's talking to me, and from a pelvic health physio, I'm like, no, girl, that cannot be normal. Something there is not right. You need to get more examination done. You need to speak with other healthcare professionals. Something else is going on. And I figure you probably agree with me that something else seems to be happening. What do you think could be happening to her?
Yeah. I think so essentially, how old is she now, by the way?
So she's 20. She's 28. She'll be
28
29.
now. 28 now. And she's been having painful periods since inception from her teenage
Yeah,
years.
from teenage years.
Yeah.
Early teenage years.
So certainly, Kim, I agree. That's definitely not normal in
Right.
terms of one, the severity of her pains. Once you get to the point where you're having pains that is disruptive to your life and
Right.
affecting your ability to function, whether professionally or otherwise, then we're looking at something that's abnormal. And then obviously you're also mentioning that she's having painful intercourse.
Right.
And,
Extremely
and
painful.
yeah. So it would be useful to get some more information though. So for example, when is the period most painful? Is it like she's having pains leading up to the periods? Like it actually starts before the period starts, or the pain is just coming out when the period starts. Also, as it relates to the pain in the intercourse, is it when the penis is going in, or is after the penis is in and thrusting that she's having pains? Because that's useful.
Okay, so
You know.
for the pain leading up to the period, why would that be important to know?
Yeah, so when we talk about painful periods, there are a number of things that we could be thinking about as a cause. Right, the more common things would include, for example, something called endometriosis,
Right.
adenomyosis, another common cause, uterine fibroids. So when we and in a small subset of patients, depending on the age, it may actually be just a normal developmental process. So, for example, it's quite common for young women, who are just starting to their periods, to have painful periods.
Right.
But as time goes by, it gets better. All right, and that's the reason why so many women are labeled and told, okay, it's normal,
It's normal.
and then
Right.
they just accept it. But so endometriosis, before I go into it, we probably have to just kind of give an idea of what it is. Right?
Yeah.
So endometriosis is really where the tissues that normally line the inner part of the uterus find themselves outside of the uterus, inside the abdominal cavity and the pelvis.
Right.
So that tissue called the endometrium is a tissue that sheds every month when a woman has her period,
Right.
and that comes out through the vagina as bleeding. We see that as a period, as a menstrual effluent. With endometriosis, the tissues that are inside the pelvis now undergo the same process. Generates inflammation, sheds, it bleeds, but there's nowhere for it to go. So
Right.
all that inflammation is in the pelvis, causing pain, discomfort, and over time can cause scarring. It can cause things to get stuck together, on the inside.
Right.
And so the classic history is that the patient will have pain. Sometimes it will start even before the period starts.
Okay.
And then, right, and so that now is sometimes a clue.
Yeah.
And that also quite often is associated now with that pain during sex. Because the scarring that's happening on the inside, the inflammation on the inside, whenever the penis is thrusting, it is tugging on the scar tissue, and that's what's causing pain. So that's the reason why it's useful to get some information.
To know. Well, I can say that being around her, definitely her period would start like before her pain would start long before her. Well, not long, probably like a day or two before her
few
period
days, right.
actually starts.
Right.
Can't tell you much about the sex because we've never gotten in details where that is concerned. But what kind of information would help in knowing what diagnosis you're leaning towards when it comes to painful sex?
Yeah. So before I even get to the painful sex, let's look a little bit more about the period pains, right?
Okay.
So, for example, Adenomyosis is similar to endometriosis in the sense that it's really caused by that tissue lining the womb being found in an
Right.
abnormal place. In the case of adenomyosis, it's actually in the muscle of the womb.
Right.
And you know,
Right.
the walls of the womb is formed by is just muscle. So what happens is that when a woman is seeing her period, if she has adenomyosis, there's bleeding into the muscle itself, and that's literally tearing those muscle fibers apart. So the
Right.
periods are very
Ouch.
painful, you know, and over time, that all of that blood trapped in the muscle becomes fibrosed, and the womb just gets thicker and thicker. And so over time, it leads to heavier bleeding as well. Okay,
Right.
so adenomyosis is similar to endometriosis in that the pain may start even before the periods. Okay,
Right. Okay.
uterine fibroids now can cause pain, but most times it's slightly different. Patients with uterine fibroids as a source of their pain typically have what we call spasmodic pain, which is usually it will start after the period starts, and you know the patient will tell you they find that they feel severe pains just before they pass a clot.
Oh.
So essentially, the womb is working to expel
Right.
something, and that is really what's causing that spasmodic type pain, which is different from the congestive type pain which endometriosis and adenomyosis has. So that little bit of information is quite useful, eh?
Yeah, I can see. I can see that.
Yeah. So it's quite useful.
Interesting.
Now, you're asking about the sex.
Yeah, it was.
Yeah. So in terms of you know, whenever you have painful sex, it's important to know, to have an idea of how
And
what
when.
exactly is painful.
Right.
Right. So, for example, if the pain is during insertion of the penis, okay, patient is saying, okay, the pain is when the penis is going in,
Right.
then most of the time you're probably dealing with either something like
Vaginismus.
probably not even vaginismus, probably lubrication issues. So most of the time it's something as simple as lack of adequate lubrication,
Okay.
right? Or especially if the male member is quite large,
Yeah.
then you know that lack of adequate lubrication leads to a lot of friction, and so you're literally trying to force the penis
Right.
in, and that is causing pain. And so that's probably one of the most common causes. It's also quite common for women who, for example, who may not have had sex for a long time, or this may be their first initiation. Right?
Right.
We call this superficial dyspareunia. That's the medical fancy name for it. Superficial dyspareunia. Now, and then of course, in a smaller subset of women, you have what you call, like you were saying, vaginismus, which is essentially where the muscular tone in the vagina becomes very strong. The vagina essentially clenches down when there is sexual during intercourse, right? Now, that is different from deep pain and deep penetration or deep dyspareunia, which is where now you're having pain during thrusting usually. And pain during thrusting is usually a sign of inflammation in the pelvis or scarring, right? Because what is happening here is that once the penis is in and it's pushing into the vagina, it's stretching on that scar tissue. So that's important.
So there can be instances where they would have superficial pain, and because they always have superficial pain, they don't get to the deep penetration where they probably also have issues with the deep penetration as well, right?
That's certainly true. But what you'll find is that most women tend to, unless the issues with superficial pain or dyspareunia is severe, they tend to work through that, at least initially. And then, you know, it's usually, if it is that the superficial is so severe that they can't bear it, or they find that they're having deep dyspareunia, that usually drives them to come
Right.
in, you know.
Right. That is true. All right.
So if a woman is coming in and saying that she can't tolerate sex because the penis can't even get in, or then you know there's likely to be something wrong.
Right. All right. So basically, from what the history that you collect from the patient, you can get an idea of what is happening, and you have the direction towards your diagnosis. But you've got information, and based on what you're saying, they're like adenomyosis and endometriosis. They're pretty similar. So what do you do now to figure out which one diagnosis you can definitely pinpoint and say this is what's happening?
Yeah, good question. So now we move, in terms of doctors and medical professionals, we have a number of different tools. One is what the history, history is really what the person is saying, what they're feeling, what they're experiencing. And then examination is the next step. And then we have investigations after that. So the next step now would go into examinations. Right. And there are certain key things that can help us to begin to differentiate. So for example, when we get down to the abdominal and the pelvic exam, and one of the things I'd like to say to patients is, if you are having a gynecological problem, expect your doctor to do a gynecological exam. Too many of our women either are underserved, knowingly or unknowing, because they don't have a thorough clinical assessment. So in a case like this, the gynecological exam would involve at least the tummy, as well as the doctor taking a look inside the vagina with a speculum and doing what we call a bimanual exam. Absolutely. Which essentially what you're doing is trying to see and to feel the genital organs to make sure, to see if there are any abnormalities. Right. All right. So if, for example, there are uterine fibroids, then the uterus may be enlarged. It tends to be what we call irregularly enlarged, because of course the fibroids are growing off different parts of the uterus. So it doesn't have this nice smooth outline, which is different from adenomyosis now, where the uterus can be enlarged, but it tends to be more globular and smooth. And so that's what, for example, one of the clues. With endometriosis, you may actually have endometriotic deposits even in the vagina. Sometimes you pass a speculum and you take a look, you can actually see endometriotic deposits in the vagina. Or when the doctor is doing the examination, he may feel areas of nodularity in keeping with scar tissue being deposited in different areas within the lower pelvis, usually behind the womb. And they may find that there is a certain amount of tenderness in the pelvis, okay? And that may indicate inflammation within the pelvis, which inflammation can be due to infection, or in this case, more commonly, maybe due to something like endometriosis. All right. So that's the next step in terms of the clues. And then now, after that, we go into investigations. And investigations now, most of the time, you will perhaps find that you're going to have a start out with a screen for infections, like sexually transmitted infections. You're going to be looking at doing an ultrasound to at least look at the outline of the womb and the lining of the womb and so forth. Now, one thing that is key to mention about ultrasound, Kim, a lot of the times, a patient may have features of endometriosis, and they'll be sent to do an ultrasound, and they're told that the ultrasound is normal. It doesn't show any endometriosis. And unfortunately, that is taken by the patient and even some clinicians to mean that they have ruled out endometriosis, and that's not the cause. But it's important for us to understand that ultrasound does not pick up endometriosis. All right. So in most cases, most women with endometriosis will have a normal ultrasound. Okay. All right. What you may find is that if the endometriosis has severe features, so for example, there's collection of blood in the ovaries, what we call a endometrioma, which is a certain type of ovarian cyst, then you may be able to see that, or if there are pockets of collection of blood in other places, then you may be able to see that. But in most cases, you won't necessarily pick up ultrasound,
With the ultrasound.
endometriosis and ultrasound. Just clues. Yeah, just clues. So, for example, if you're very, the ultrasound may find that there's evidence that the ovary is stuck onto the womb or so, then we may suggest it. But it's not a tool.
So then basically what you're saying is when the ultrasound actually picks up endometriosis or picks up clues of endometriosis, it's usually at a severe point.
Yeah, usually at a severe point. Not severe necessarily in the patient's symptoms, but in terms of what inflammation that's happening on the inside.
That is very, because that would explain why a lot of women would have seen the doctors, done the exams, and been told that nothing is happening, you're okay. And, the women end up leaving feeling gaslighting because they're like, no, I know something is wrong. I know something is not right with my body. But here you're telling me that you did scans, you did an ultrasound, and I'm okay. So now you leave the women thinking that, hey, it's just me. It's just me.
That's right.
And
absolutely
then
right.
that leads
so
to
it's important that we say
trusting medical doctors and looking for alternatives because they've been failed a lot of times by the medical system.
That's right. Yeah, definitely. And I think that's the reason why, it's important that we're doing the kind of things we're doing now. And, and that's what we want to do. We want to educate, empower women to understand their bodies and to be able to be an active participant in their own
and for them to leave understanding the steps, because if you go to your gynecologist and you go with these problems and you didn't do a pelvic scan, like a actual internal assessment with your doctor, that should send off alarm bells. Like, hey, this isn't it. This isn't a thorough assessment. This is not the type of assessment that I would need to get a proper diagnosis. You wouldn't know that. So people always think that everyone knows because you are exposed to certain areas of medicine, or you probably by chance have had great doctors your entire life. You don't know that there are persons out there who truly, they have no clue. They trust the doctor. The doctor is the authoritative figure. So they trust them. If they're the authority and if they say this is so, you're going to believe them until they failed you. And then you have a negative view on the doctor and you're seeking help from person that you probably shouldn't be seeking help from. And we have a problem.
Yeah, that's true.
Yeah.
That's true. And sometimes, not because I'm a physician, but sometimes patients may actually, gynecology is a very sensitive specialty.
Yes,
it's very intimate. And, a woman, is rightly so protective of her own body and space. And so, she may prefer not to have a gynecological exam because of the kind of, invasiveness of it, So that's also something to consider and in the process. So that's really important as well.
Yes, that is definitely an important point because if I didn't know the importance of seeing a gynecologist and seeing one regularly and meeting good gynecologists like you and the team at Healing Gynecology, I probably wouldn't be so willing to just go on a bed and do a gynecological exam because it's pretty intrusive. And the first time I did one, I was telling the doctor that the speculum it's a little too big, you can try a smaller one, and his response was, "My nose is bigger than this." Like that's what the doctor said to me at 17 years old, and I was like terrified. I was like, "Are you serious?" And so sometimes it's the bedside manners that make you want to say no. If you have a calm, reassuring voice that they seem like they have your best interest at heart, you will listen and you will do what they ask you to do because it's for you, it's for your own good. But if you have someone with some bad bedside manners and go up on the bed, take off your clothes, nothing you're gonna feel some type. We're gonna be like, no, I don't want to do that. I don't want to do that.
Right.
And I'm all for women saying no if you feel uncomfortable. You can say no, like
Right.
say no, but don't say no and never get it done. Say no and
Right.
find someone who you feel comfortable enough with to get on that bed and get that exam done, because it can make your life so much better if you actually know the diagnosis and actually get the treatment that you need. And we'll talk about
Yeah.
treatment, won't we, Doc? Maybe not in this.
Yeah, we will.
but-
Now then, listen, we'll talk about treatment. But let's, yeah, but you're absolutely right, Kim. And I think I'm glad that you're saying that to women, is that you know, you deserve, you have a right to quality care. You have a right to be treated with dignity and respect. And you should never hesitate to seek that out. If you're not happy, if you're not comfortable, and
Right.
continue looking. So I agree with you. One of the advantages of, and I'm going to go into the investigations, but one of the advantages of a thorough examination is that it allows diagnoses to be made with less expenditure of resources.
Right.
Understand? So, for example, if I talk a little about the investigations, you'll understand. So, let's talk about endometriosis. So, the gold standard really for diagnosing endometriosis is something called a laparoscopy assessment.
Right.
A laparoscopic assessment is essentially where we go in, take a look inside the tummy, because really and truly, if you're going to say somebody have endometriosis for certain, you can only say that for certain if we're going to go in, identify those endometriotic deposits, take a sample of it and send it to the lab for testing.
Right.
So laparoscopy essentially is a surgical approach that allows us to do that without making an incision in the tummy, a large incision. So essentially a camera can be placed usually through the belly button, allows us to go in, and if needs be we may place other small incisions on either side of the tummy to allow us to put in working instruments to be able to visualize, and we can identify the deposits, sample them, and then that can confirm. So in the past we used to do a lot of laparoscopies
Right.
to diagnose endometriosis. But what happens is that you realize that this is far more common. This thing is so common that a lot of women were undergoing laparoscopic procedures to make a diagnosis that can easily be made with a thorough clinical assessment.
Right.
Because what you'll find is that there is a fairly good correlation between patients who have classic clinical features of endometriosis and actually laparoscopic findings. And it's cheap without the cost of the surgery and without the risk of the surgery. And so that's the advantage. And sometimes just based on the clinical assessment, mean history and examination, you have enough evidence to start treatment for these patients. Yeah.
Question. So, is the same laparoscopy also a treatment?
Yeah, very good point, Kim. Yeah. So when you talk about treatment, you see that laparoscopy is both diagnostic and therapeutic. So
I hope you guys weren't opening up women to diagnose them, then come out and go back into treat. You're just doing it one time, right?
Well, you know what? You know what's funny? Yes and no. Yes, in most cases, because you have what is called a diagnostic laparoscopy. Okay, which oftentimes you would go in, you look and you identify, you take a sample, and unless you had gotten consent from that patient to implement surgical treatment, you really can't. Because remember now, the risk profile. No, but listen. No, I'm going to. Let's think about it, Kim.
I'm listening.
Everything has its risks, right?
Yes.
And everything has its risk. And the risk of a diagnostic procedure is substantially lower,
right,
than the risk of a therapeutic procedure, especially for patients who have endometriosis, or especially those who may have severe scarring on the inside.
Right.
Because remember now, when you go in and depending on what surgery you're going to do, you can injure structures on the inside. There's a risk of hemorrhage. There's a risk of injury to the bowel, to the bladder, to the, so, and not every patient will require surgery to treat their endometriosis.
I understand that, but couldn't we get one
Yeah.
form that say, in the event you need, like, sign the dotted line?
Well, some people do. Would have gotten dual consent for diagnostic as well as operative laparoscopy before going in. So the patient says, okay, doc, if you go in and you find that there's something abnormal. And nowadays, I think that's pretty standard.
Right.
But it changes from
Thank God for
location to
modern
location.
medicine.
Yeah, but also we have to consider the finances as well.
Yeah.
Because there are many times where you may have, certainly in countries like Jamaica, for example, where the vast majority of persons may not be insured.
Right.
A woman may be able to easily afford a diagnostic procedure at the time, but may have a challenge in affording
The upper.
an operative procedure.
Right.
So there are many factors that come in. 1, patient safety. 2, the consent issue. 3, the cost issue.
Finance.
And 4, what is the right treatment?
That
So,
is
for
true.
example, the vast majority of patients with endometriosis, we can find that we can control their symptoms without needing to do surgery.
Right.
So if you go in and you see endometriosis and they're diagnosing it, and the patient is responding to medical treatment,
They
then
have to do surgery.
it wouldn't be justified to putting her through the risk of surgery unless it is indicated for a specific reason. You
Understood.
understand?
Understood. So that is why it's important that the doctor that you go to can do and does a proper clinical examination, so that
Right, because-
you can avoid having to do diagnostic surgery later on or ever, and you can start getting the treatment that you need right away instead of having to wait until you get the appointment, because there's elective surgery, and in cases where you have, like with COVID, where you couldn't have done elective surgeries, you'd have been there waiting for a diagnosis when you could actually have gotten one with your clinical exam.
Yeah. So so there are specific cases in which the diagnostic assessment will be indicated, but it's
right.
case by case.
It is case by case, right? But all right, Doc. So, this week's takeaway. What would you say are the top 3 things that our listeners should take away from this episode?
Yeah, top 3 things I would say. 1 is that painful periods that are affecting the quality of life, that's not normal. 2, if you're having sexual intercourse and you're having pain that is affecting your ability to enjoy sex, that's also not normal. And so that needs to be checked out. And I think the third thing, which is probably you would want us to make sure we mention, is the importance of ensuring you have a thorough clinical assessment whenever you see your gynecologist. And that you make sure you find somebody who you're comfortable with or who treats you with the kind of dignity that you deserve to be treated with. I would say those are 3 things.
So, friend, if you're listening, the top 3 things that you'd want to take away is 1, your period should not affect your life. 2, painful sex that stops you from enjoying it, that is the normal. And 3, make sure that you have a proper clinical examination when you go in to see a gynecologist. And if you're not comfortable, go seek out another one. It is okay to say no, I do not want that done, but it should be no, you don't want it done with that person, and you can go on and get help. Make sure you get help from a medical practitioner, preferably a gynecologist. Right, Doc?
Yeah, definitely. I agree. 100%.
All right.
Let's put some.
Just want to make sure I said what you said. And we want to dig a little deeper into investigations and even into some of the treatments that are out there for women experiencing painful periods or painful sex. Right, Doc?
Yeah, so we're going to be talking a lot more about the treatment. Yeah, I like the sound of that.
Right.
No, we spend a lot of time talking about problems. It's about time to talk about some solutions. I like
Absolutely,
solutions.
solutions. So stay tuned, guys, for the next episode where we will be discussing treatment as well as investigation of painful periods and painful sex. See you on the next one, guys.
Rose among thorns. Yeah.
Welcome to the first episode of the Women's Health. It's the Women's Health Podcast, right? That's what we're doing, right? Good.
The Women's Health Podcast with
Kim
and Dr. C.
All right, let's go.
We lost Kim again.
I am back.
Phone overheat again.
Again, blazing up. No, this phone
But at
not
least
where
you'd
I
have
love.
done
I
one.
need to get another device. Right?
Ali,
Exactly.
get your what?
I need to get another device by next Saturday. Not my own.
Well, at least we have one showdown.
Should I get an
Yeah,
iPad? I can't afford a MacBook right now. And I don't know what they're going to tell me wrong with mine.
That's the thing. Because
They say I sound the same.
the same, because the advantage of the dynamic mic is that it's right up. It cuts out some of the ambient sound.
The fan is on the top.
So like I'm snapping my finger now. You hearing me snapping my finger?
Yeah.
You hearing it?
Yes.
Oh, okay.
It's not, as she said, it's not a magician.